make how important it is and how people are ignorant. I mean, professor and unit head of Ops Gynae did not know that her mother had SUI. I mean, she probably never asked her directly. I mean, if it was his son, so I can understand, but daughter, I think this he should have told. So that is what I want, that we should ask them active questions, direct questions, and if they have problem, we can definitely help them. And it's not that operation is required all the time. 70-80% problem can be sorted out by medical treatment. So that is what I wanted to highlight basically. So and it increases with advancing age. So okay. So I mean, rather than going to too many details of that, so it's basically same thing, that complaint of sudden compelling desire to pass urine, which is difficult to defer basically. Okay, and nocturia, all of us know, is the complaint of interruption of sleep one or more times. So once usually everyone goes in the washroom in the night, but more than that we usually take as nocturia. And it is basically an urge incontinence, again same, basically not leakage of urine associated with urgency or sudden compelling desire towards. So different this thing, but grossly it is same. That means nocturia, frequency, urgency, sudden able to pass urine. It can be classified further as wet means with incontinence, and sometimes dry without incontinence. That means patient has the sensation. She is trying to have the same, but she has not actually leaked. So that is called dry. But most patients have wet, and even the dry we have to treat it accordingly. So maybe if I make any mistake or this thing, so madam is there too. Okay. So I mean, prevalence, I told you, keeps on changing, about 16 to 27%, and most commonly reported symptom is frequency. So frequency of which is the most common, and other symptoms like urgency, urge incontinence. So overall almost 60% respondent with symptoms consult a doctor, but only 27% receive treatment. So many times they don't themselves consult. Even if they are consulting, doctor may overlook it. So that is what I want to highlight it. And all of us know, I think this part may have been covered by sympathetic, parasympathetic. Anatomy has been covered, madam. So little bit, I mean, so we have got for the postgraduate sympathetic and parasympathetic system. So if just see, yeah. So if you see, that's the bladder, urethra, and sphincter. This thing. So ultimately, it is the from the pontine maturation center is there in the brain. Okay, and that sends sympathetic this thing. So sympathetic and then parasympathetic. So sympathetic basically causes inhibition of the bladder detrusor and stimulation of the uh, bladder sphincter. Okay, so now all of us are sitting here, so our sympathetic is taking a lead. Okay, but after the lecture is over, then suppose we want to go to washroom, so at that time sympathetic has to take a back seat, parasympathetic will come into play. So parasympathetic will cause detrusor contraction. So if detrusor contracts, then urethra has to relax, otherwise there will be dyssynergia. So that is very important. So that so at that time sympathetic will take a backseat, parasympathetic will come into focus. So parasympathetic will make the bladder to contract, so patient will like to pass urine. So at that time urethra has to relax, dilate, then only you are able to pass urine. So patient starts to pass urine, and suddenly cobra snake comes, and then suddenly we can stop it. So then comes the pudendal nerve. Okay, so even at that time, I mean, the sympathetic has taken a backseat, parasympathetic has ordered the bladder to contract, bladder has contracted, and it has ordered the urethra to open. It was opening, but suddenly, like or someone comes, some male comes in our bathroom, something like that. So we suddenly stop urine. So that is the pudendal nerve. So pudendal nerve is a protective mechanism. That's how it works, and it is the same as 2 to 4. What the postgraduate, when you are giving pudendal block analogy, the same nerve basically. Okay, so that is how we did. So same thing. So this will be relevant even for the M1, M2, M3 receptors, because when we are discussing drugs for urge incontinence, that is how it will work. Okay. So diagnosis is mainly clinical based on history and symptoms. So typical symptoms of urgency, frequency, nocturia, etc. In absence of UTI, urine microscopy do, culture do, that is sterile. Okay, so and there is not need to do many investigations. Urodynamics are not necessary. American College RCOG clearly, I think madam will agree with me, not required for a routine case of overactive bladder syndrome, even for SUI. You can even do sling surgery. Only for complicated cases we need urodynamic study. So but if you do urodynamics for them, so that will show the detrusor overactivity. I mean, during the bladder filling phase, at that time detrusor have to relax, then only it can fill up. But if there is detrusor overactivity, then the detrusor will contract during the filling phase. So if you are doing a aerodynamic study, so there will be basically backflow, in other words. So that is, the detrusor should remain relaxed, but it contracts. That is called detrusor overactivity, and is the important cause of urgency in these patients. So mainly history taking is very important for any case of overactive bladder, not only overactive, but any case of like urogyne patient. Normally in gynae ops, we are very busy. All of you must be seeing so many patients. So we don't spend 3, 4, 5 minutes, madam, in India. There you spend 15 minutes. I worked there, I know. So, but here we have to be very fast and all. But in patient of urogynae, please do spend little more time. So I tell the patient that Mataji, you just wait for, half an hour, I'll see you at 12 o'clock, but I want to see in details, more detail. So that is important for them. So, and you have to take complete detail, history, urological, obstetric, gynae, neurological, medical, surgical, social, psychological, radiation, pelvic trauma, etc. So it is very important to ask how much she is drinking water, tea, coffee, etc. What is making her to pass urine. So you have to find her urinary irritants. You have to find what helps her. So many times I offered cup of coffee to my friend professor of ophthalmology in Delhi, and he refused. He said I had drunk coffee once and I went to washroom 10 times. I said, how can it be possible? So he could take tea. So that means his bladder was, irritant. Coffee was irritant to him. So tea, coffee, similarly, some people have coke as an irritant. So we have to find our own. So we have to see the patients, tell her that what makes you pass urine at that time. So it may be coke, it may be certain fruits for that some patient. Usually the simple water is helpful. And so that is important. And similarly, is the patient, and then another concept is going on, and many patients in India and UK also maybe same thing. So the ladies get up in the morning, they have 2-liter water can. The first thing they do in the morning, they drink 2 liters of water. In the day also they drink. So 3 to 3.5 liter of water. So they think by taking, lot of water, their face will glow like Katrina Kaif. Please, I mean, the effect of water on face is doubtful, but effects on bladder is real. So the face doesn't glow, the bladder glows and leaks urine. Okay, so that is what that simple diary can help you. Just overnight or 24 to 48 hours diary. Some people have used it, so that we take. I mean, I'll be saying how much they're drinking water. So, I mean, at least 5 patients have treated in life just by decreasing without any medication, without any surgery. So, just by reducing the amount of, so 1.8 liter is required for our kidney function. So that is must, but more than that, they should reduce the amount put. So that is the what history will tell you. Okay. Similarly, some patients are on diuretics. This patient may be hypertensive and she is on antihypertensive. The cardiologist and physicians are very fond of giving diuretics. That is a part of the combination regimen. So just by changing the diuretic or reducing the dose of diuretic or changing to another antihypertensive, maybe all is required. Then some patient may be having some neurological issues. One of my patient had multiple sclerosis, so that was the cause of resistance. So those are complex issues. We will not discuss that in our lecture. Neurogenic bladder, etc. They are too difficult. But the history taking is very, very crucial if such patient is there. Like, especially if we are ourselves doctors, we are very become emotional about our own mothers and also. I keep getting patients. One not professor but consultant gynecologist from Delhi. She brought her mother to me. Dr. Sharma, my mama has got SUI. So she made auntie to lie down on the bed. She said, "Mama cough." So mama coughed and sure, and there was a parabola of urine. Okay, and she said, just put tape in her. I said, please hang on, let me see. I palpated and the bladder was filled full, man, almost 800, 900 ml. So the bladder is, overfilled, and then there is raised in abdominal pressure, the patient will leak urine. But that is not SUI. That was overflow incontinence. So had I put a tape in her, I would have caused her more damage. So sometimes we have another, our own professor head of microbiology, she brought her mother and got her admitted also because she was getting it free, tape and all. And then when I assessed the total history and all, then I found she had got neurological some issues, multiple sclerosis. So I didn't operate upon her. So this is very important. Otherwise, when we operate on, then the whole blame will come to us that, ever since you did this surgery for me, I'm having this issue. So we have to be very careful. Medical treatment definitely. Namaskar, ma'am. Thank you. So that is very, very crucial, that detail history taking is very important. And then sometimes radiation history of, like, patient had cervical carcinoma in the past, so radiation cystitis and all can be there. So in that case the bladder capacity reduces significantly. So patient bladder may not hold more than 30-40 ml urine because of that. So that history will tell you, pelvic trauma also sometimes. So all these, so that's why detailed history taking is very, very crucial for all these patients. What medications he is taking, sometimes antipsychotic medicine and etc. So that is very, very important. And of course incontinence history, character of incontinence, length and severity, impact on quality of life, associated bowel problem. Okay, so that is, so examination again is important. Overall examination including cranial nerve examination, neurological examination, gait, etc. Because then you can find out some neurological cause also. Okay, and one of my patient had actually, she was treated for meningomyelocele in childhood. and you know, so there was scar mark on that and all, and she was herself a dental doctor, and now she didn't have sensation, so she would pass urine and all. So those are difficult, altogether different issues. No, in that case, don't put tape or anything like that. Their incontinence is because of different reason. So that's why history taking is very important. Past history, past medical history, past surgical history, some neurosurgery, neurological history. And so these are the condition of mucosa, urethral mobility. This will be more useful, and you know, for patient of SUI. Then demonstration of incontinence, vaginal prolapse, any associated prolapse. Many patients have got associated prolapse, and then this, and of course bimanual examination, and the neurological examination. I told you mental status, mobility, lumbar sacral sensory, and reflex, etc. Those are important. Okay, and then a small voiding and intake diary, as I told you already. So instead of 7 days diary, our simple weekend diary can also be made convenient for the patient. So that will just tell that patient is not drinking too much of water or the other drinks, you know. So that will also ideally should be almost equal, like 1.8 to 2 liters should be intake, and output can accordingly 1500 1200 ml accordingly. And urine analysis, simple urine analysis can be done complete microscopic examination. So that will help us cells if there is UTI, and then of course you can do urine culture. Okay, if that is has to be ruled out, so when indicated, not routinely. Post-void residual urine is important to know. Pad test is just to confirm patient has got leaking urine. So we give a pad and we weigh it before, suppose it is 10 gram, and after that it should become 11 gram, 1 gram rise in weight. So if the patient walks with it, so that will tell if the very, like, you know, we are not sure whether patient had got urine incontinence or not. So that can be used for that. Okay, but usually you don't have to do these tests. It's very clear cut diagnosis and all. So then role of cystometry usually not routinely required for all cases according to the guidance, but we can do the complicated or difficult cases. So it will tell us the bladder filling phase, involuntary detrusor contraction, low bladder compliance, urethral obstruction, impaired detrusor contractility, and directing treatment. So we can get it. And now why to treat is very important, because it affects the quality of life of the patient. So physical, social, sexual, psychological, occupational impact is there, and associated comorbidity have to be treated, and sleep disturbances also. If someone has to get for 4 to 5 times in the night, so obviously how will she get up in the morning and do her work? No. So depression, poor quality of life, all these become important. And the elderly are also at increased risk of falls and fractures from rushing to the toilet. I mean, recently one of our doctor patient, she had the problem. So she got up at 2 o'clock, and the maid by mistake, you know, had put the mat up, you know, upside down. So she just slipped and then fractured her ankle. So it's important, and in fact, like my mother-in-law stays with us, so she has to go 2 3 times in the night. So I keep the light always 24 hours open for that room, no, bathroom, and we have made a railing on the side for her. Okay, so that is very important, is to avoid fall, because if they have fracture neck or femur at this age, no, then I mean they become totally bedridden, and also we have to be very careful. And I always tell the patient never to lock the room, no, when they are going to the washroom, to never to, because if they fall, then someone need to come to help. So that's what I tell my mother-in-law, no, that I mean we are only there, who will see you. So just if you fall and all, so that is important to please, that you know, we must avoid fall and fracture. It happened, I mean, so the room was locked and she fell inside, then she was shouting, but nobody could help her. They had to break open the door. So that in the house, I mean, only family members are there. So these are small things, practical things which have to be done to these patients. So now the patient is there. I mean, we have made the diagnosis of overactive bladder syndrome for the postgraduate from mainly from the history taking, physical, like, you know, urgency, frequency, nocturia, and UTI has been ruled out. Okay, and you have ruled out there is no other causative factors for it. I mean, diabetes, neurological sequelae, or excess fluid intake, and all that. So she had got truly urgent continence. You don't have to do urodynamic studies, but I mean that will just show the overactive, that was the overactivity if you do it. Okay, so now what we can do, simple first is the lifestyle changes. The good thing is for overactive bladder syndrome, treatment is basically medical treatment, not surgical treatment. Treatment for SUI, someone will be doing, I think madam will be doing, will be surgical treatment, usually tapes and other things. But overactive bladder syndrome treatment is almost universally medical treatment. So that's what I mean. You PGs and others, they can help their family member, their patients easily without any need of learning surgery. It's very simple thing to learn. So simple weight reduction will help her. So like, you know, otherwise also she will lose weight, so it will help her, and she will gain confidence also. One of my patient had got such severe incontinence, so her real sister was staying across the road, and she had not visited her for 3 years because she was leaking urine. Okay, so she was a case of SUI. So ultimately, I think I did a birth for her, and she became, now see, every week she goes to her sister, or her sister comes to her. So they both sit together, chat together, they bitch around about their daughter-in-law, let them. at this age, no, that is useful for them. And ultimately now she has lost 3-4 kg weight, and now see this sparkle in her eyes. She said, "Doctor, I want to lose more weight," and it has improved her knees. Otherwise, her knees were gone, so she was to get them replaced also. So overall, otherwise they're just what is happening. I mean, if you see go to any house, one elderly lady sitting on a corner on one cot in the house, corner of the house, and family member give her 2 roti at lunch, 2 at dinner, their duty is over, and they don't mind it, but they are waiting for her to die, and she is also waiting to die. So that is very sad. They can be really helpful. My mother-in-law stays with us. She has looked after my son so much, my daughter both. I mean, they are so much, fans of her nanny. She only looked after. I mean, all I think our kids are looked brought up by dadi or nanny only. So that can be really helpful. And how much expenditure is on them, and they give so much unconditional love. So I think we can really help their life by doing this. So then avoid coffee, tea, as I told you, smoking also, and physical therapy. Arnold Kegel's exercise, all of you must have been told already. I won't go into detail, but they definitely improve urethral closure, though they are more useful for SUI, but they are useful for overactive bladder syndrome also. And you don't have to do actually electrostimulation biofeedback, but if you have the machine available, I think Madam can tell us better about that. So that can be used, but otherwise, but important is that she contracts the right muscles. Many times they're just contracting the abdominal muscle. So I think it's better if you train, madam, one of your own doctor here. You can physiotherapy. We have got a physiotherapist with it. We trained her in pelvic floor exercises. So that saves our time. So I send every patient to her now. So she spends like 10 minutes with her. They don't have much to do, no, these physiotherapists, etc. So we can use their helper, but first we have to train them. So that can be important. And bladder training for the postgraduate is nothing but the retraining of bladder. So what we do in this case is basically we ask the patient to pass urine by clock. Like, so I asked her that how much you can hold. She said no, not more than 1.5 hours. So we can start with 1.5 hours, otherwise 2 hours. So like she gets up at 7 o'clock, so 7 o'clock, 9 o'clock, 11 o'clock. Next week we increase by 15 minutes. So 7 o'clock, 9:15, 10:30, and 9 like that. Then 7 o'clock, 9:30. So every week 15 minutes. Along with we are giving her some anticholinergic drugs which I will be discussing. Okay, plus she is doing pelvic floor exercises. Plus she has reduced tea, coffee, water intake. So all these things help her. So decrease tea, coffee, decrease water, okay, pelvic floor exercises. She has reduced 1 to 2 kg weight over 3 to 6 months time, okay, and now she is doing bladder training. By every week she is increasing by 15 minutes. So all these things will help her, and the lifestyle modification I already said. So lose weight and all, we can help her in. I mean, sometimes if she is too much of weight, then her next question will be, you only tell me how to lose weight. No, so easy to say, but then you can give her orally stat or some medication can also be given. Otherwise, just like avoid junk foods and all that thing, as we tell our children basically. So same day, so, and empty bladder before going to sleep. So all these things will definitely help. And this is the how to bladder training I already told you, like increase by every 15 minutes. So this will increase ultimately. The comfortable level will be about, if we can go to 3 to 3.5 hours, that is fine enough. Another peculiar thing you will see, someone patient, my patient says, she said like she goes 20 times in the day. In the night she says only get up only once. So that is a very positive thing. You'd ask her, if the bladder is really non-compliant, it passes urine with just 30 to 40 ml. Even in the night she should pass urine, she should leak urine, and she should wet the bed. She doesn't. So we take it as a positive reinforcement. Okay, that if your bladder, if she is sleeping fine, then her bladder can hold for 3-4 hours. So same thing we can use in the daytime also. Okay, because if it was a really like after radiation she studies blood is 30-40 ml, then she has to go every hour, even if in the night she has to get up. And another thing is important is that whether sometimes the patient, like sometimes we are in the night, we are getting up at 2 o'clock for some tension, something, like for post PG, some ma'am scolded you in that day for thesis or something like that. So, so sometimes if we are getting up for that, my thesis is not over, my paper is rejected, whatever. So then if we get up at 2 o'clock, then, by all means we go, okay, then that automatically we go to washroom. So it's the other way around actually, because we were not sleeping, so we went to washroom, not the other way around. But if the patient has to get up to pass urine, then we call it nocturia. So that is also important. I mean, maybe has sleep issues. So that is also important. So this is the exercises I already said before. Yeah, biofeedback you can use, electrical stimulation, medical therapy. Now this is the key therapy. So for all urge incontinence treatment is usually medical treatment, and we have to use tricycline, like antidepressants sometimes, but most commonly used drugs are. So they all decrease the detrusor activity, as I told you, and increase bladder capacity. Okay, they mainstay, and but they all of them cause little bit of dry mouth and constipation. Okay, so this is the list of also. I'll just say oxybutynin we were using it, but not very much. But now transdermal has become available in UK. So I think madam must be using it a lot, but in India not available. So usually oxybutynin causes more side effects. But the dose was 5 milligram thrice a day. So instead solifenacin 5 to 10 milligram a day. So solifenacin 5 milligram once a day, or derifenacin 7.5 equivalent dose. So I start with derifenacin is available in Dairy Task, Dairy Long, 2 3 companies. So 7.5 OD you give for 3 months. Along with that, pelvic exercises, bladder training, and decreased tea, coffee, decreased weight, etc. All that go hand in hand. So this is the, I mean, I tend to use this more often and see them after 3 months. And don't give them realistic expectation that you will, the incontinence will improve by 40 to 50%, and gradually another 10% or so. So which is good enough. Never give them 100% guarantee and all. So that is good for them, and that you have to, and then so you can give tolterodine also, and then mira background 25 to 50 milligram a day. So that can, but adverse effect is hypertension. So what mira background basically is beta 3 adrenergic drug. So if the patient has got cardiac issue, then avoid mira background. Is that clear? So mira background 25 milligram a day can go to 50, but avoid it in heart disease patient. But if the patient has got narrow angle glaucoma, and then avoid these oxybutynin, solifenacin, derifenacin. So in that case, you can use mira background, because glaucoma can be worsened by that. So that is basically all these are. Imipramine is usually for nocturnal enuresis, 25 milligram OD. And combination also we can give, like initially 7.5 milligram of derifenacin, and along with that we can give 25 milligram of mira background. So that can be done. Thank you. Okay, these are the last varieties, like sacral neuromodulation, cystoscopy injection, and augmentation entroplasty. Okay. So, so understand basically improved understanding of pathophysiology, contribution of alternative receptor, better understanding of receptor. So I just ultimately in the end I finished here. So that means diagnosis is very simple, history based. Any patient of urgency, frequency, nocturia in absence of UTI, and then good history taking, good examination, and give her decreased tea, coffee, reduce weight, and one anticholinergic drug like mira, this usually solifenacin, derifenacin, or mira background. The two can be combined also. And usually I give this medicine for 2 years in a maximum. After 2 years I stop the medicine. So by this time she should have lost 2-3 kg weight. By her bladder training has made her bladder better. And plus she had decreased tea, coffee, and pelvic exercises has made her muscles better. So I give her drug holiday for 3 to 6 months. After that, patient comes back after another 3-6 months or so, and I ask her. So some 30 to 40% patient want to go back on the drug. So after 3 to 6 months, you can again give. So up to 4-5 years also you can give drugs, because long term action, I think madam will agree with me, can cause cognitive dysfunction, especially in elderly patients. So avoid 5 to 7 years, especially after 70 years of age. But couple of years can be done. So can we have the next lecture? I go in continuity. So any question about overactive bladder syndrome? Any question about overactive bladder syndrome? Next wala laga
I
do.
think yesterday we had discussion, so it was reinforced.
Okay.
And then what you were talking, that from the doctor's family you came across cases who had full bladder and they brought her for stress urinary incontinence, and the other example was also from a doctor's family that for tape there was neurological problem.
Okay, man. Yeah,
So I am happy to say that in my department, of course, all the OBGYN, they are very well versed with all history, examination, and they will never decide on to management unless they have themselves taken the history and done a
yeah.
examination.
Thanks to
So
you,
we
madam.
don't see this type of cases where doctors, they are
Achha, okay.
ignorant
Thank you.
about their own
Oh,
family
thank you.
members.
Yeah,
But
Professor
anyway,
Seema Hakim came all the way to AIM Delhi, and she started Urogyne here. I'm very happy that we could I mean contribute to AIM. Thank you, madam, for your special interest and making us powerful that way. Yeah. So this topic is little bit complicated and all, and even I'm not very much expert in it, but little bit maybe I'll take madam's help if I have any queries about it. Okay. So this is the avoiding dysfunction and urinary retention. So it's more like retention and all. Sometimes we have to take the help of urologists. So we are not urologists but urogynecologists. So but But I mean, what is important, like in the males, the prostate is the single most important cause. So males have more voiding dysfunction, females have more of urinary incontinence. So that is, yeah. So that is it. So, but still, and so female voiding dysfunction has been defined by ICS as abnormally slow or incomplete micturition, based on abnormally slow urine flow rates or abnormally high post-void residuals. So, so this is important. So in other words, obstructive symptoms basically. Patient is unable to pass urine. So that is more difficult to treat, and sometimes it used to happen in olden days, like especially males, the gonorrhea also used to cause urethral constriction. So still gonorrhea can cause, but much rare. But mostly, so the classification can be so like neurogenic voiding dysfunction, and this thing. So what is important here is in the obstructive element is there. So usually ladies tend to have, I mean, if you see 10 is to 1 ratio, males have more obstructive symptoms because of prostate, females have more incontinence issues. But voiding dysfunction is less common in them, and it can be neurogenic like voiding dysfunction or low and or functional or anatomical. So okay, yeah. So this is the basically micturition cycle we have already done, bladder filling phase, bladder emptying phase. Okay, that we have already done. Voiding reflex. Okay, so neurogenic lower unit at dysfunction refers to abnormal function of either the bladder neck, and its sphincter related to a neurological disorder. Okay, so this is, there are various, I mean, classification. You don't have to go into that much detail, but the lesion can be supraspinal lesion, suprasacral, infrasacral, peripheral, and anatomical lesion. So for the postgraduate, you don't have to go into that much details and all, but just grossly, like just like we are doing hypothalamic pituitary ovarian axis. So on the similar basis, this classification is also there, and there another lipids classification is also there. So that also says like neurogenic, bladder, motor paralytic, autonomous, etc. So just to complete the list basically, and that is the ICS system. So in this case, you can still say there can be storage phase problem, voiding phase problems, and all. So all these can cause basically patient may have difficulty in passing urine. Okay, so how to evaluate this patient in this case, like what we were evaluating the patient for urge incontinence and all. So here we have to see usually the, I mean, bladder is trying to contract. So either the bladder is not contracting well, so detrusor hypoactivity, or the sphincter is tight. So that these are can be the only two causes, when why is the patient not passing, able to pass urine. So that's why we have to like take a detailed history, फिजिकल एग्जामिनेशन, यूरिन एनालिसिस, वार्डिंग डायरीज, ये उसी का है ना। अच्छा ना, हाँ, चलो
क्या हो गया? क्या हो गया? किस चीज का?
यहाँ तो खुल रहा है ना। अच्छा, ओके 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 ओके। Okay, so basically this is how we evaluate the patient. Okay, again, yeah. So history taking, physical examination, urine analysis, voiding diary. So it's almost similar as we were doing for the urgent incontinence patient. And then in this case, maybe uroflowmetry, urodynamics are useful for the patient, and we can even do ultrasound, cystoscopy, and according to the risk classification to be performed. Okay, so the patient, if low risk, I mean the renal function will be normal in that case, and unit tract imaging is also normal, but the urodynamic will show synergistic voiding if assessed. In case of moderate risk, I mean, these functions will become abnormal ultimately. Like in high risk patient, renal function will deteriorate because of the obstructive element. It's just like, any obstructive element will ultimately make the patient to have hydroureteronephrosis, and renal failure can also happen. So ultimately lower, if you see this can make the patient to, like, ultimately that's what our worry is, that poor compliance, and ultimately the patient can have hydronephrosis and even loss of. I have seen patients of like renal failure just because one of my patient had, and Dr. Seema madam, this patient had, she was I think in late 70s. So her daughter brought her and she was crying. So she was a renal failure patient on this like dialysis, and she had stage 4 prolapse, and nobody was touching her. And somehow it clicked to my mind that could it be that ureter kinking and all. But I told her that don't expect any help, anything better for your kidney function, but we will try. So I spoke to my HOD anesthesia. She said you admit her a week in advance. So I admitted her, we got her, gave her dialysis and all. Ultimately, I operated upon her, but I told her frankly that don't expect improvement in your renal function, but definitely you have got this fourth degree precedency and all, so it may improve. And can you believe? And ultimately, gradually within a month, her renal function improved, and ultimately she went with dialysis free. So that was a unique case. So